And one other note on housekeeping is that at the end of the talk, we will have an opportunity to ask Dr. Mueller questions. Please do wait until the end of the talk to submit your questions, at which point I will ask you either to unmute yourself or and ask your question yourself, or I can read out your question. At any rate, let's get on with our show today. I am absolutely delighted to introduce Dr. Julia Mueller to you, our speaker. Dr. Mueller is a research associate at the MRC Epidemiology Unit, and she is working within the program of prevention of diabetes and related metabolic disorders in high-risk groups. Currently, she is leading a quantitative analysis on an NIHR Programme Grant for applied research on developing and evaluating scalable behavioral weight management programs. Her research to date revolves around the management and prevention of non-communicable diseases such as cancer, other chronic respiratory diseases, diabetes, and obesity. She has a particular interest in the potential of technology to support healthy lifestyles and disease management. During her PhD, as well as her postdoctoral work, Dr. Mueller has taken on many interdisciplinary projects, and she's worked closely with researchers, both in the health sciences as well as the computer sciences. And she has co-authored a textbook on developing medical apps and health interventions. Since she joined the MRC Epidemiology Unit in May 2020, her research has been focusing on evaluating the effectiveness of using non-specialists and technology to deliver behavioral weight management programs. And with that, we're very excited to hear what you have to say today, Dr. Mueller.
Thank you so much. Thank you very much for that kind introduction. And thank you everyone for joining the talk this evening. Let me just share my screen so you can see my presentation. There we go. Yes, so I'm going to talk tonight about supporting weight management during COVID-19, and I'll be presenting some findings from a recent study that we conducted. So I have prepared a few slides about myself, but Aishwarya has very kindly already introduced me with a lot of details, so thank you so much for that. But yeah, so just a quick overview. We focus on developing and evaluating individual level approaches within my team. So at the MRC Epidemiology Unit, there are a few teams that focus on more environmental level approaches to preventing diabetes and obesity and related metabolic disorders. But we focus very much on identifying high-risk groups and then offering individual level behavioral interventions. And specifically, the program that I work on at the moment is on developing and evaluating scalable weight management programs. So that's important because a lot of existing weight management programs are led by specialist healthcare professionals. They're quite expensive. So basically there's not enough to go around for everyone who needs them. So we're focusing on developing interventions that are more inexpensive and that can be scaled up to have a good population reach. In terms of my background, I studied psychology and health psychology, and then I've worked in like quite a big range of different health conditions. So for example, I've worked in lung cancer, chronic obstructive pulmonary disease, and also a range of different other conditions. But what sort of ties all of my work to date together is my interest in digital interventions. And as Aishwarya also mentioned, I have sort of summarized that expertise that I've gained over time in a book that I co-authored with a computer scientist. So we kind of worked together to put our expertise together on medical apps and mHealth interventions. Yeah, so that's enough about me. So now about the topic of my talk. The study that I'm going to present tonight is on weight gain during COVID-19. So during the pandemic, there's been social distancing and isolation measures in place. There's been a lot of disruption of routines and a lot of stress and emotional turmoil. And I'm sure this is familiar to many, if not all of you. And we know that during such times, this tends to lead to changes in eating and physical activity patterns and adverse mental burden. And that combination often leads to weight gain. And why is it an issue if people are gaining weight? This is so increased BMI and obesity are risk factors for a wide range of different health problems. So obesity is the 5th leading risk for global deaths, and a raised BMI is a major risk factor for many conditions such as diabetes, heart disease, and cancer. And so our prediction at the start of the pandemic that this would lead to increased body weight and BMI is being supported by emerging evidence. So here we see some findings from a population-based survey that was conducted in Germany. And so this graph looks a little bit busy and complex, but basically it shows body weight and it shows BMI. And it shows this for the time frame from spring 2020 onwards, and then for the same time frame in 2019. And the key take home, what we see here is that from spring 2020 onwards, we see a marked increase in body weight and BMI. And similarly, our prediction that there would be adverse mental burden is also being supported by evidence that's emerging now. So here are some findings from the UK household longitudinal study. And I've picked out a few items that relate to psychological distress, such as having problems concentrating, loss of sleep, not feeling useful, less capable of making decisions. And so in green, we see the proportion of people reporting these issues during COVID-19. And in red, we see the proportion before COVID-19, and we see that there is a marked increase during the pandemic. So the take home from this would be that even if people maybe aren't reaching clinical levels of depression and anxiety, we definitely see an increase in psychological distress. So what we can conclude from all of that is that we need more support for people living with overweight and obesity during the pandemic, because based on previous research, we know that during disruptive times, they are particularly vulnerable to weight gain. And so at the start, when the pandemic sort of hit, our team were already in the process of developing an intervention, a weight management intervention, and it's called SwimM, which stands for supporting weight management. And it's a digital intervention. So it's delivered completely remotely. So kind of ideal for use during the pandemic. So we then decided to take this existing intervention and adapt it for use during the pandemic. And we call it SwimCovid or SwimC. And we evaluated this in an online randomized controlled trial. So the primary aim of our study was to evaluate the effect of SwimC on body weight compared to standard advice during the pandemic. And our secondary aims were to evaluate whether SwimC achieved improvements in eating behavior, physical activity, mental health, and well-being. Now, before I get into more detail on our methods and our findings, I want to talk a little bit more about the intervention itself and what it actually looked like. So SwimC is based on acceptance and commitment therapy. And the images shown here on this slide, they portray quite well what ACT is all about. So on the left, we see how people tend to deal with negative internal experiences, such as negative emotions or urges and cravings for particular foods. So we often tend to struggle against them. And it's like a constant internal battle which takes up a lot of energy and resources. And the idea behind ACT is that if we can learn to accept these internal negative experiences, and instead of fighting against them, we can just sort of learn to accept them and instead focus on the values that are really important to us and choose our actions based on our values, then they lose that kind of power over us, as shown in the image on the right. And the idea is that we would then have more energy and resources to devote to other things. Yeah, so our SwimC intervention was based on ACT. It's a self-help program. It's digital in form of a website, which I'll show you in a moment, and it's guided. So that means that there was contact with a coach throughout. And the contact was completely remote via telephone and email. And importantly, it was that the coaches were trained non-specialists. Instead of specialist healthcare professionals, we worked with lay people, and they received some training, some online training, and also a very specific coach manual. And this is what makes the intervention much more inexpensive. And the aim of the intervention was to support adults with overweight and obesity in their weight management, physical activity, and emotional well-being during the pandemic. And this is what the SwimC website looks like. So this is the homepage, and you can see there's several sessions that people click their way through. They do one session per week, and there's 12 sessions in total. And within each session, there's psychoeducational content, and this is delivered in form of these text boxes with very short, brief messages written in very accessible language. And there's also various exercises, including reflective exercises and also behavioral experiments. So in this example, participants were encouraged to develop their own physical activity plan and write out in detail what physical activity they plan to do for the next week and how long and when, etc. And any of these exercises that participants completed were then available to them up here in the swim aids. So if we click on the swim aids, you can see there's here are all the different kind of exercises that people complete throughout the program. So for example, there's a weight tracker, there's a meal plan that they develop for themselves. There's also the physical activity plan. So they have them all in one place so they can revisit them. So now that we have a better idea of why we did the study and what the intervention looked like, of course, the key question is, does it work? And I'll try to give you a slightly more helpful response than the one shown here. So we conducted a randomized controlled trial. And I was just kind of aware that there might be people in the audience from different disciplines, and I think study designs go by different terms in different disciplines. So what I mean with a randomized controlled trial is basically just an experimental design. So we randomly allocated people either to the intervention or the control group. The idea being that if we randomly allocate, then any sort of random variation between the two groups should be averaged out, and any differences that we measure between the two groups should be due to the intervention. So in terms of our study specifically, we recruited online through obesity and weight management organizations, mainly via social media. So basically, various obesity and weight management organizations used their social media accounts to help promote our study and help us recruit participants. And potential participants then completed some online screening questions to check eligibility. So they needed to be at least 18, have a BMI of at least 25, and own a set of scales so they could weigh themselves at home. And they then completed baseline assessments, and this was done online via self-report because, of course, during the pandemic, we need to limit face-to-face contact as much as possible. And the outcomes that we were looking at are weight, mental health, various psychological determinants of weight control, physical activity, and well-being. Participants were then randomized either to the intervention or the control group. And in the intervention group, they received access to the SwimM website, which I just showed you. And in the control group, they received standard advice in the form of a leaflet on diet, physical activity, and mood during the pandemic. And 4 months later, they again completed the assessments, the same as at baseline, and again online via self-report. And this is the point that we're up to now, but we are also planning a 12-month follow-up. So now we can start looking at some of the results. So we managed to randomize 388 participants, which is excellent because our target sample was 360. And you can see that we have some loss to follow-up, but nothing too dramatic. And actually 84% completed weight at follow-up, which was our main outcome of interest. And of those that were randomized to the intervention, around half completed at least 8 sessions, which is around 2/3 of the intervention. In terms of the sample that we recruited, we can see that the majority of the sample are female, which is a common issue with research on health interventions. Women are usually more likely to take part than men. Also, we can see that we've got quite a highly educated sample. So you can see here, most people fall into the groups of either university degree or equivalent, or higher degree or equivalent, which is, for example, master's or PhD. So actually 63% of the sample are university educated. And also the majority of the sample are white. So overall, men, those with lower education levels, and ethnic minority groups are less well represented in the sample. And now, of course, the key question is, did our intervention have an effect on body weight, which was our primary outcome? So in this graph, we see in orange, the orange line is the SwimC group, the intervention group, and the blue line is the standard advice group, the control group. And it shows mean weight from baseline to 4-month follow-up. And what we can see here is that both groups lost weight. Participants in the SwimC group lost a little more weight than the control group. And the difference between the two groups after adjusting for a few other variables is 0.6 kilograms. So participants in the SwimC group lost 0.6 kilograms more than the control group. So to pick this apart a little more, what this means, I've tried to show in this diagram the confidence interval. And maybe for those of you who aren't so familiar with this, the confidence interval is basically a range of values where, simplified a bit, it's a range of values where we can be fairly confident that the true difference between the two groups lies within that range. And as we can see, our confidence interval for that difference between the two groups in weight is quite wide, and it does include 0. So it's possible that there's no difference between the two groups. So basically all values within this confidence interval are reasonably compatible. From this, we can't conclude that there is no difference between the two groups, but we also can't rule it out. So essentially the bottom line is that it is possible that the difference that we measured between the two groups is just due to random chance. So there's no clear indication that our intervention had any systematic effect. The other interesting thing to note is that, as I said, both groups lost weight. So even the control group lost some weight, which is not what we were expecting. So we were expecting the participants in the control group to actually gain weight. One reason for this might be the way that we recruited. because we recruited via social media accounts of weight management organizations. So our participants were people who were following weight management organizations on social media. So probably they were already quite motivated to lose weight from the outset. Another reason might be that maybe people really liked the leaflet that we used in the control group. Maybe it was sort of a stronger intervention than we thought. We did find indication that our intervention had an effect on cognitive restraint. So cognitive restraint is a domain of eating behavior. It refers to conscious restriction of food intake to control body weight. And here, as hypothesized, the intervention group increased their cognitive restraint of food intake in comparison to the control group. We also found an effect of our intervention on uncontrolled eating. And this is, again, a domain of eating behavior. And it refers to the extent to which people tend to lose control over food intake. And here again, the differences in the hypothesized direction. So participants in the intervention group reduced their uncontrolled eating compared to the control group. The third domain of eating behavior is emotional eating. And for that one, again, the confidence interval included 0, so it's possible that there was no effect on emotional eating. We also found an effect of our intervention on experiential avoidance. And this is a psychological construct that I personally find a bit difficult to grasp. So I'll try to show it a bit using an example. So experiential avoidance describes attempts to avoid negative internal experiences, even when doing so creates harm in the long run. So for example, on the left, we see high experiential avoidance. So if someone, for example, is craving some food, this creates an uncomfortable internal experience, this craving. They might then increase their food intake in order to make that uncomfortable internal experience go away. So they're basically avoiding it. Whereas on the right, we see low experiential avoidance. So for example, if someone is craving some food, but instead of trying to make that discomfort go away, they accept the discomfort and commit to their values of being healthy and choose alternative responses that are in line with their values. That would be low experiential avoidance. So instead of avoiding that internal experience, they sort of accept it and move on. And what we see in our study is that participants in the intervention group, as hypothesized, reduced their experiential avoidance compared to the control group. And according to the theory behind acceptance and commitment therapy, reducing experiential avoidance should lead to improvements in eating behavior, which would include increased cognitive restraint of food intake, less uncontrolled eating, and less emotional eating, and that should then lead to improved weight control. So some of this we saw in our study. So we've got the reduced experiential avoidance, the increased cognitive restraint, the reduced uncontrolled eating. As I said, with emotional eating, there's no clear indication that it had an effect. And we don't see that effect on the actual body weight, but it is possible that those constructs take a little more time to exert effects. And then finally, we found an effect of our intervention on well-being. And this one I find really interesting because when you look at the graph, you see that well-being didn't actually improve in the intervention group. It stayed the same, but it decreased in the control group. So basically the control group during the pandemic saw a dip in well-being, whereas in the intervention group, well-being remained the same. So it looks like our intervention had a protective effect on well-being. So to conclude from all that, so our intervention is remotely delivered, it's scalable, has good population reach, It's very inexpensive because it is digital and because it's led by trained non-specialist people. It's also very strongly based on evidence and theory. And we did find that differences between the groups tended to favor the intervention group, although not all of them reached sort of statistically significant differences. And we did find that our intervention, SwimC, improved psychological determinants of weight control, and it had a protective effect on well-being. So overall, quite promising. But we should bear in mind that the generalizability of the sample is limited. As I said, men, those with lower education levels, and ethnic minority groups were less well represented. And also, due to our recruitment methods, it is possible that our sample was quite highly motivated from the outset to lose weight. Yeah, so just a quick overview of what we're doing now. So we are continuing to work with our SWIM intervention. We've added more sessions, we've added more coach contact, adapted the content based on people's feedback. So I think it's overall a stronger intervention now, and we're currently conducting a feasibility study with that. And of course, before I finish, I want to acknowledge all the hard work that went into this study from the whole SWIM team. Of course, it was not just me working on this. There's a whole team behind this who put in a lot of really hard work, especially in terms of getting the study up and running so quickly at the start of the pandemic. It was really brilliant work from everyone. And also, of course, I need to thank the wider MRC Epidemiology Unit, because this research wouldn't have been possible without the structures such as field team, data management, IT, etc. So that's all from me for now. Thank you so much for listening, and I'm very happy to take questions and comments.
Excellent. Thank you very much, Julia. That was a very interesting talk. I honestly thought at the beginning you were just going to fat shame us, but thank you. And we already have a question, so let's just kickstart the question session with that. Jay, would you like to ask a question yourself, or shall I read it out? Okay. Anyway, Jay wants to know how did you recruit your non-specialists? How much training did they have?
Yeah, sure, no problem. Yeah, so the in terms of recruitment for the SWIM COVID study, we needed to be a bit more creative because we didn't have much time. So some of the coaches were people from within our team or from other teams within the university. Some were more widely recruited, but overall, they're all people who have no professional training in weight management. So for example, I acted as a coach as well, and I have no training, it's basically specialists we would define as, for example, a dietitian or a clinical psychologist specializing in obesity, whereas all our coaches were non-specialists. The training that coaches received was we received online training, which I think was about an hour or an hour and a half from a specialist. And we also had a coach manual that was, it was very like specific and structured and all written out in terms of how to communicate with people. Yeah, so that was pretty much it. I hope that gives a bit of a clearer idea.
Yeah, I think that makes sense. It's a very interesting approach, to be honest.
It makes it much easier to recruit the coaches because they don't need any background knowledge at all, right. And it's a lot more inexpensive than working with sort of specialists.
Maybe I missed this, but do your participants know that their coaches are actually non-specialists in diet and weight training, so on?
I believe that is specified in the participant information sheet.
I see.
Not 100% sure, but yeah, I'm pretty sure that that's quite transparent.
Okay. So Ella wants to know, at what point during the pandemic did you realize that this intervention should actually take place?
Yeah, great question. So I think within our team, it was clear quite early on. And it's because we know from previous research, see there's, we've never been in this kind of situation before. But there's a lot of research on how sort of disruption of routines would affect people's weight. For example, during holidays or during the Christmas period. So we knew from that people with overweight and obesity are particularly vulnerable to weight gain during those kind of disruptive times. And we also knew from that small weight changes during such times can become permanent and then lead to more weight gain over time. So that was something that within the team was recognized quite early on. And also actually several obesity and weight management organizations reached out to us early on and said, people are asking us and saying they need more support. Is there anything you can offer? Which then gave us that extra motivation to be like, okay, we have an existing digital intervention. Let's adapt it to what people would need during the pandemic.
She'd like to follow up with a question about, did any of your participants show signs of sugar addiction? And if so, did it lead to any different results?
So that was not measured by us. So yeah, basically I can't comment on how that would affect results. Maybe something to consider whether we should be measuring in future studies, but yeah, it wasn't part of our assessment at this point.
Yeah, that's very true, because you're right. I mean, you'd probably, I mean, there's other weight loss management programs that would actually help you sort of manage what kind of food groups you're ingesting very specifically as well, such as Weight Watchers, for example.
Yeah. And I guess we weren't focusing on any sort of, the SwimM intervention is less about educating people about any sort of particular food groups. It's more about learning the sort of the psychological strategies and skills to help people with that process of accepting uncomfortable internal experiences and being able to choose your actions based on your values. Yeah.
So over the years, I have been part of Weight Watchers and certain others. So you said that you recruited your participants from social media of other weight management programs as well. Do you happen to know how your system compared with those where you basically paid for subscription or something? Because I think that's quite a big incentive, having paid a monthly fee.
Yeah. So we've worked with Weight Watchers in the past on several trials. So I'm trying to think. I think so they're usually 3-month programs as well. And trying to think, I think the differences that they've measured in the past have been more like over a kilogram difference. So, but I don't have the data right now to look specifically into it. But those programs, they're a lot more intensive, as you say. So I would imagine that they're not quite comparable. The idea with our SwimM intervention is that it could actually be an adjunct to programs like Weight Watchers. Because what we see often is with programs like Weight Watchers is that people will lose a lot of weight initially and then regain over time. And the idea is that SwimM is something that you can offer to people afterwards to help them with weight maintenance. So that's what we're testing actually in our feasibility study at the moment.
Right, we have a question from Eleanor Rist. Eleanor, would you like to ask the question yourself?
Sure, I can do, because it's a long one. Sorry about that. When you were talking about SwimC, it reminded me of a weight loss app. I don't know if you're familiar with it, called Noom. Because Noom's entire thing is it promises to be the end of weight loss. It's psychological based and sort of is the idea of kind of healing your relationship with food. But there are lots of critics that say it's just a calorie counting app that costs about £250 a year for a bot to coach you. And I wanted to ask if you knew about this, because obviously sort of SwimC reminded me of the existence of things like that. So
Yep.
Do you think that there's sort of real efficacy in strategies like this, or do you think that sort of essentially, do you think there's a way that SwimC, if kind of, or strategies like it if done correctly, could end up being sort of marketable weight loss strategies for people? Or do you think that actually things like Noom take that the wrong way and just end up exploiting people's desire to lose weight?
Yeah, I think that's an excellent question. I think it's hard for me to say because I'm not familiar with the content of Noom. Mm-hmm. I've seen it in various ads, but don't actually know sort of like what psychological strategies they're promoting and how they're doing that. So yeah, difficult for me to compare. I will say if there is criticism that it's just a calorie counting app, that does sound quite different from SwimC, because SwimC is definitely not about calorie counting. As I said, it's much less about sort of specific diet advice and more about learning these kind of acceptance processes. And it is very much evidence-based, and there is a lot of good evidence that that intervention based on acceptance and commitment therapy can be effective in terms of weight loss. So someone from within our team did a systematic review and meta-analysis on that. So as I do believe that there is a lot of potential for ACT-based interventions. Sort of the message behind it is a lot about self-compassion. So the idea being that when you're sort of constantly hard on yourself and like struggling against yourself, that it eats up all your resources. And then how are you going to have anything left to like to manage your weight? And it's a lot about sort of being very kind to yourself. So again, that I think makes it very different to sort of standard calorie counting approaches. So I don't know if that helps to give you sort of a bit of a idea.
Yeah, I completely agree. Thank you very much.
Okay, thanks.
Thank you. I believe JD has a sort of follow-up question. I'm not sure if you'd like to unmute yourself this time. Okay.
Right. I managed it this time. It was disappointing that you had mainly your participants from the white community, and I wondered whether there's an inference that perhaps weight is a cultural aspect for some groups, and whether you looked into any of the assumptions that we could learn from the lack of interest from Black people in your research.
Yeah, so I don't have any evidence to pick that apart at the moment. So it's a bit hard to say. I think my initial idea was that it's like the fact that we have less ethnic minority groups is that probably due to the way we recruited, and that we didn't reach the right groups. But based on what you're writing, I can also sort of see an argument to be made for maybe we are reaching them, but they're less interested for some reason. So yeah, it's definitely very much a concern. We don't know, say for example, if we translate SwimC into other languages, we don't know how well that's going to translate culturally. So yeah, I think it's definitely a concern, and it's something that we want to address in future. So what we're doing for our next study is, rather than recruiting via social media where we have that kind of self-selection bias, we're recruiting via referral from various other services. So hopefully via that strategy, we're going to get a more mixed sample. So I think after our feasibility study, will hopefully be preventing people from taking part. Yeah, at the moment, I can only sort of make assumptions, but yeah, I think it's definitely an issue that warrants further investigation.
Thanks.
Thank you.
That's a very interesting point, but sort of taking it from a genetic background perspective, you'd probably be more likely to get cleaner data in terms of like actual weight loss. Wouldn't you agree? If your participants were from more or less a similar genetic background, would that be something to think about? And if you were going down that road, do you think you might say ask for referrals through a GP practice or something, and you might get more pools of people coming in through that as well?
Yeah, so that's what we're that's the road that we're going down now. I think just at the start of the pandemic, we needed to move as quickly as possible, so we didn't have time to go via just as you were saying, we're hoping that by recruiting via other services that we'll get like a bigger pool of people. And yeah, we should then hopefully be able to have a better idea of who the intervention works for and maybe who doesn't it work for at the moment, like what we need to adapt. And we're also doing a lot of qualitative evaluation as well, and I think that will help to pick apart some of those things as well.
So Ella would like to know if there's a particular reason why women are more likely to take part in these trials.
Yeah, it's really hard to say. I've looked into the literature quite a bit because it's such an issue that we see over and over again. So a bit hard to say. I think sometimes some issues are around how masculinity is perceived in society, and how I think sometimes there's this idea that if you admit to having some sort of health problem and seeking help for it, that's perceived as less masculine. So that's an issue. I think also there's some research around the fact that men prefer a slightly different approach to women in these kind of health interventions. So they often prefer a much more structured approach. So there might also be an issue of sort of how the intervention is presented and whether men think that they get any gain from it. So I think there's two issues there. One is how the intervention is perceived and maybe how it's presented. And then there's also the issues around sort of like social ideas of masculinity. Yeah.
So ultimately in your final, in the extension of your study, your readouts are going to be the same, or are you hoping to look for more aspects of this? Like in terms of like, are you just looking at just loss of weight versus cognitive behavior, that sort of thing? Or are you planning to incorporate additional features?
So we are preparing at the moment to include more other measures apart from just loss of body weight. So potentially we can look at things like percentage body fat, or waist measurements, because there's different, obviously body weight can be biased, and there's a lot of other sort of anthro measurements that might give a more accurate idea of whether people's health is actually improving. So that's what we're working with at the moment with teams within our unit to incorporate more measurements of that.
Okay, that's excellent to hear. Are there any other questions for Julia? Okay, thank you again. That was really wonderful, and thank you. Please do join me, everyone, in thanking Julia for that very enlightening talk, and thank you all for attending today's Live from Lucy. I do hope you will all join us again. I encourage you to look at the college website for more updates on Live from Lucy. Next week, I'm sorry, the 28th of July, my apologies, we will be having a talk by Dr. Karen Thomas discussing fatigue and various neurological conditions. So I hope you will all join us there for that. Thank you again.
Thank you all so much. Thanks.